Patient's here.
Oh boy, got some blood going.
Yeah, this is never blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in
For 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Hey guys, so let's do a little intro real quick. This is going to be an introduction to a lot of the episodes, and I'm going to try to keep it quick. Um, Surprise to all my classmates and everyone listening. I hold a PhD in psychology. I successfully defended my dissertation back in 2019 after all final revisions were complete. I did all that before I was 30 years old. That right there was when I was still hard charging straight out of the Ranger Regiment. And so, like, I was taking on a massive amount of just stuff to do, just trying to break my own will to see if I could. And so, I went to psychology and I got my PhD. Now, I walked away from the field of psychology after I did a statistical assignment for my graduate level statistics class. And I saw that the most that I was going to be able to make as just a research psychologist here in the state of Texas at the time was like 70 grand. And so I was like, you know what, that's not worth it. And then it was just reinforced that after I successfully defended my dissertation, I went through and my first job as a PhD was editing grant proposals for a major university in the area. And I only did that for like less than 100 days and found out it wasn't for me, so I left. But regardless of all that, some of the accolades that come along with that PhD was in 2018 when I've submitted my first round of revisions. Um, I was asked by the APA to speak at the APA conference in Chicago. And in 2019, I was asked to speak at the APA conference in San Francisco. And then I was asked to speak at the APA conference in 2020 over Zoom, and then in 2023 at Washington, D.C. Now, the one that I regret not going to was the one in 2023 in D.C., in Washington, D.C., because that particular APA conference, the topic was going to be over violence, domestic violence, partner violence, and stranger violence, just violence, period. And a lot of my research revolves around violence, namely the predatory nature of people who suffer from antisocial personality disorder. And that is my specialty is ASPD. And then I have this affinity for personality disorders. Now, another set of accolades was I was also asked to speak at the 2018, 19, 20, and 22 or 23 EPA conference, the European Psychological Association in Budapest. And again, due to my illiquidness when I was in grad school, I was not able to afford to go to any of those conferences. And then the 2023 conference in Washington, D.C., I was in nursing school, so I wasn't able to go to that one either. And I was really bummed about that one. All that to say is I specialize in personalities, namely ASPD, but I know enough to kind of get around with a lot of other different stuff. So let's kind of go ahead and get started. I don't know, I haven't listened to the episodes yet, but back in the DSM 3 TR or the 3R, because this TR stuff is new, either the DSM 3R or the DSM 4R or 4TR, um, they had an access system, and the access system plotted like your mental health disorder and then any medical diagnosis that you may have. And it took a more holistic approach to the person And now the DSM is mainly just like a book of statistics. It's just going to tell you within the last 3 months, have you done this? Or in the last 6 months, have you done this? And it doesn't really necessarily take into consideration maybe some of the other medical diagnoses that you may have. Now, when you're talking about like personality disorders, you can get away with kind of separating mental health from medical, like medicine. But when it comes to some of like the neurodevelopmental disorders, or maybe some of the other disorders like the somatic disorders, or maybe some of the disorders that are like your neurotic disorders, like your anxiety disorders, they need to be tied back in with medicine. They don't need to be parsed out separately. They need to be coincide together that way, because it deals with neurotransmitters, neuromodulators, and all these other things. So your dopamine, acetylcholine, your serotonin, and norepi and stuff like that. Like it all ties together. And so I think it's foolish to kind of pull that apart. Now, moving on, I'm talking fast because I'm trying to keep this brief. Um, so they had this access system that they did away with, and now they're at this like stupid cluster shit that they done, and I don't particularly care for it. Um, but we're going to be talking about. I did no introduction to trauma and stress disorders because, again, trauma. This next iteration of episodes for our particular exam and our particular program is going to be covering the neurotic disorders. And so in psychology, we classify different types of disorders by like neurotic, personality, somatic, stuff like that. So the neurotic disorders are going to be like trauma and stress, anxiety, OCD, eating disorders. Um, so interestingly enough, like I didn't do an intro on trauma, even though like I go to a therapist for my combat PTSD from when I was in Ranger Regiment. Um, but let's talk about anxiety. Now, anxiety is a very broad umbrella because it encompasses a whole bunch of disorders. But namely, we're probably going to be talking about just generalized anxiety disorders. But under anxiety disorders, again, it falls all under this neurotic disorder umbrella. Is you're going to find your OCD, this obsessive compulsive stuff like hand washing. Your clothes have to be facing a certain way. You can only put your clothes on this color hanger, or you can only eat this type of food on this day. It's a way to control. It's a way to have some sort of control whenever you feel like you don't have control, and that's what they use. And then I don't know if the episodes are going to get into it, but trick. It's hair pulling. I can't say the real name for it, but it's called trick. It's like trichosponus or something like that. But it's hair pulling, and then you could either have hair pulling and then drop it, or hair pulling and eating it. Um, and when you start getting into the hair pulling and eating it, you start getting into pica, which is also considered, at least in some literature that I've read, they also consider pica a neurotic disorder. And then they classified it looks like eating disorders under this neurotic umbrella. And so when you got eating disorders, you're talking about like um, anorexia, bulimia, and then you have like your binge eating disorders, and then your cyclic binge eating disorders, like what you find in like wrestling, bodybuilding, and other sports that require weigh-ins. You get those kind of like disorders, those cyclic binge eating disorders, and they should classify those as a anxiety disorder, especially like anorexia and bulimia, because those are anxiety related or neurotic related at least. But yeah, so I wanted to do this intro just to kind of like let you guys know. I don't know if the podcast episodes are going to talk about it, but the APA moved away from the Axis system like 15 years ago or longer, right? It was either the DSM-4 or the DSM-3 that they got rid of it, and they went to this cluster shit. So if the podcast hosts, the AI podcast hosts are talking about the Axis system, just know that the Axis system is an old system by the APA that plotted out mental disorders and medical disorders. And it was, in my opinion, it was an amazing system. And I don't know why they went away with it. But now we got this like bullshit cluster shit. Okay. So, regardless of all that, we're going to be going over anxiety disorders. As like little word to my classmates, yes, I might know a lot about psychology. I do. But I don't know nursing psychology. Psychology is one thing. Nursing psychology is something completely stupid different, right? So, yes, I still have to study for nursing psychology because guess what? We're getting tested over nursing psychology. We're not getting tested over psychology. So yeah, when we get to personality disorders, I will probably do a very extensive intro regarding personalities because again, that's my strong suit. Personality disorders. It all spurs from like a trauma related response, and that's how you develop these weird personality disorders like borderline, maybe ASPD, uh, histrionic, stuff like that. Uh, but yeah, um, so yeah, be on the lookout for that. I might do an episode with the intro, without the intro, or maybe you just have to fast forward 15, 20, 30 minutes to get to the episode. I haven't decided what I'm going to do yet. But regardless, it's still going to be great information, especially from me. Because it's not every day that you're going to be getting a 1 inch wide, mile deep dive on personality disorders. Because all you guys want to sit there and wonder why your man doing this or why your woman doing that. And personality disorders are typically the answer for a lot of that. So, regardless, man, I want to go ahead and get off here and just upload the episode. But yes, there's a little intro from me, yours truly, Dr. Guy. Don't ever fucking call me doctor because I hate it. I don't like it at all. I hate it with a fucking passion. So don't ever call me doctor. If you do, I'm going to get mad. All right, peace.
Imagine standing in a completely ordinary room. Maybe it's a grocery store aisle or, just your own living room.
Right, a totally safe space.
Exactly. But suddenly, without warning, your heart rate just doubles. Your chest tightens up so violently it feels like a steel band is crushing your ribs.
Your breathing becomes shallow, rapid, desperate.
Yeah, the blood drains right out of your face. It pools in your major muscles, preparing your body to either fight for its life or run as fast as humanly possible.
And your mind is just screaming that you're suffocating.
You are convinced with absolute certainty that you're having a massive heart attack and that you are going to die right there, next to the cereal boxes.
And the most terrifying part of that entire physiological cascade is that there is no lion in the grocery aisle.
Right.
There is no external threat at all. It is a massive systemic false alarm.
That is the reality of a severe panic attack. And usually when we talk about a medical diagnosis, there's a comforting expectation of precision,
Oh, absolutely. Like a broken bone.
Yeah, you break a bone, the x-ray shows a jagged white line, and the orthopedic surgeon just points to it and says, there's the problem. It's visible. It's measurable.
We really crave that binary simplicity in medicine. Broken or whole. Infected or sterile.
But stepping into the world of neurodevelopment, trauma, and psychiatric nursing just completely destroys that x-ray machine. We're suddenly navigating a diagnostic landscape that is incredibly murky.
Highly subjective.
Exactly, because we're dealing with the clinical management of anxiety and stress-related disorders. We aren't looking at a fracture on a screen. We are assessing invisible neurochemical shifts, behavioral adaptations, and, subjective feelings of absolute dread.
It requires a completely different type of clinical vigilance.
Right.
You are essentially assessing the human alarm system.
Right.
Biologically, anxiety is a brilliantly designed evolutionary tool. I mean, it's your body's way of forcing you to pay attention, to prepare, and to protect yourself.
It's functional.
Highly functional. It acts as a necessary signal of danger or a motivation for some required change. The clinical pathology, the reason patients end up in the ED, and why this material is so heavily tested on nursing board exams, is what happens when that evolutionary alarm system gets stuck in the active position.
Which brings us to our mission for you listening today. We have a very specific goal. We are taking a comprehensive clinical manual on anxiety disorders, and we are stepping in as your psychiatric clinical mentors for this deep dive.
We are extracting the absolute highest yield material.
Yes, this is the 20% of the content that will give you 80% of the understanding you need.
The 80-20 rule.
Exactly.
Okay.
So whether you are prepping for your nursing school exams, staring down the NCLEX, or maybe you're already a licensed nurse on the floor trying to refine your clinical judgment and provide safe patient care, this deep dive is completely engineered for you.
The goal here goes way beyond just memorizing a list of symptoms or, flashcards of medication.
Nobody wants a boring lecture.
No, the objective is to teach you how to think like an elite psychiatric nurse, to understand the profound why behind the clinical what.
And I love that.
We're going to build a framework that allows you to walk into a patient's room, assess their precise level of anxiety, and instantly know which interventions are safe, which are dangerous, and exactly what is happening at the receptor level in their brain.
And to build that framework, I like to use an analogy. Mild anxiety is like the low fuel light in your car. That little yellow gas pump icon pops up on the dashboard.
Right, it's helpful.
It is. It might be mildly annoying, but it motivates you to take action. You pull over, you get gas, you solve the problem.
Panic attack is a completely different mechanical failure.
It's the equivalent of the car's engine catching on fire while the alarm blares at 120 decibels and the cabin just fills with smoke.
You cannot drive that car.
No.
You cannot reprogram the GPS or casually change the radio station. The only priority is survival.
And as a nurse, your interventions must drastically shift, depending on whether your patient is dealing with a low-fuel light or a catastrophic engine fire.
Exactly.
So before we dive deep into the pathophysiology and the specific neurotransmitters, we're going to establish a high-yield master sheet. This is the core 20% that matters most.
The foundational anchors.
Let's start with the must-know disorders out of the entire psychiatric spectrum.
When dealing with severe pathological anxiety, the two heavyweights you must master are panic disorder and phobias, specifically agoraphobia.
Okay, panic disorder.
Yeah, it's defined by spontaneous, completely life-altering attacks that last anywhere from 15 to 30 minutes. They are rapid, they are intense, and they just escalate without warning.
Then we have the must-know medications. We'll dedicate a massive portion of this deep dive to pharmacology later, but what is the absolute bottom line distinction a nurse needs to make right now?
You have to draw a rigid clinical line between short-term acute management and long-term maintenance. For the acute relief of severe anxiety, like when the engine is actively on fire, you utilize benzodiazepines, medications like alprazolam and diazepam.
But those carry a huge warning.
Massive. It's a massive NCLEX red flag for high misuse and dependence potential. They are strictly for short-term use, defined as 4 to 6 weeks maximum.
Got it. And for the long term?
For the long-term daily management of the disorder, you transition to non-benzodiazepines like buspirone and the SSRI antidepressants.
We'll definitely explore the mechanisms behind those shortly. But we really cannot establish a master sheet without addressing the absolute core of nursing practice, which is safety.
Safety dictates every single action you take. During a panic-level anxiety attack, a patient experiences a complete collapse of rational thought.
They just can't think straight.
They lose the ability to recognize potential danger in their environment. This creates a terrifying risk of them just fleeing into danger. Yeah, a patient might bolt out of a clinic door and run directly into oncoming traffic simply because their primitive brain is screaming at them to escape the immediate area.
That requires immense environmental control from the nurse. And the safety risks extend deeply into the medication management as well, particularly across the lifespan, right?
Well, the clinical literature is explicit regarding older adults. Prescribing benzodiazepines to the geriatric population introduces a significantly increased risk for falls.
Because of the sedation.
Yes, the sedation combined with clumsiness and blood pressure shifts. It leads to devastating injuries like hip fractures. It's a major prescribing red flag.
The text also highlights a devastating psychological safety risk, which is suicide. The data shows a markedly increased risk of suicide in people diagnosed with panic disorder.
And the demographics here are highly specific and highly testable. The highest risk category for suicide and panic disorder includes younger female adults, specifically those who are unpartnered or without a spouse, and those with a lower education level.
The research also heavily links early childhood trauma as a contributing factor for that specific group, doesn't it?
It does. Furthermore, when looking at the pediatric and adolescent populations, the text explicitly states that social anxiety disorder represents the absolute greatest risk for youth suicide among all the anxiety disorders.
So if a nurse is conducting an intake assessment on a patient fitting those demographics, a rigorous suicide screening is not just recommended, it is an absolute non-negotiable priority.
It is the very first thing you assess after ensuring their immediate physical stability.
Continuing with our foundational master sheet, we need to talk about communication. How does a nurse speak to someone whose neurochemistry is in complete chaos?
The cardinal rule of psychiatric nursing communication during severe anxiety or panic is this: do not attempt to teach the patient.
No teaching.
Furthermore, do not ask them to make choices. Their cognitive processing abilities have completely shut down.
So what do?
You utilize short, simple, incredibly clear statements. You drop the pitch of your voice to a low, calming register. And above all else, you provide your physical presence. You never leave a highly anxious patient alone.
Which brings up the emergency response protocol. If a patient is having a full-blown panic attack in a busy hospital corridor, what is the sequence of action?
Immediate environmental modification coupled with continuous supervision.
Get them out of the hallway.
Exactly. You prioritize safety by moving the patient to a small, quiet, non-stimulating room. A large, chaotic area just exacerbates the panic, making them feel exposed and overwhelmed.
But a smaller room makes them feel secure.
A smaller, contained room can drastically enhance their sense of security, and you remain in that room with them.
I want to push back on the communication aspect for a second, specifically the rule against offering choices. Let's paint a clinical scenario.
Okay, let's hear it.
I'm a nurse on a medical surgical floor. My patient is pacing the room, wringing their hands, hyperventilating, and clearly escalating into severe anxiety. My natural human instinct, like my empathy, makes me want to offer them a distraction or give them a sense of control.
Why? You want to help?
Yeah. I want to say, let's sit down. Do you want to try this crossword puzzle, or would you rather I turn on the television, or maybe we can listen to some music? Why is offering those choices a clinical error?
It's a phenomenal question because you are fighting against human nature there. Offering a choice feels compassionate. But you have to understand the biological reality of cognitive collapse.
What's happening in their brain?
During severe anxiety, the patient's perceptual field has drastically narrowed. They can barely process a single detail in the room. In full panic, they cannot process any environmental stimuli whatsoever.
So they aren't even really hearing the options.
Exactly. If you ask them to make a choice, even something as trivial as television versus music, you are asking a brain locked in pure survival mode to perform executive functioning tasks.
Oh.
The prefrontal cortex is essentially offline. They physically cannot weigh options.
So forcing a choice upon them actually amplifies their terror.
It pours gasoline on the fire. They realize they can't answer your simple question, which makes them feel even more out of control, more defective, and more panicked. You remove the burden of choice.
Yeah.
You tell them what is happening, simply and calmly.
That foundational understanding shifts everything. To truly apply this clinical judgment, we have to look under the hood. We need to understand how stress physically alters the body.
To map that out, we first must clarify the clinical distinction between fear and anxiety.
Right.
In casual conversation, people use the terms interchangeably. In psychiatric medicine, they are entirely different entities.
The source material draws a really hard line here. Fear is a reaction to a clearly identifiable external threat.
Yes.
It's the physiological response to a stimulus that represents real, immediate danger. If a grizzly bear suddenly breaks down the door to the studio, my physiological reaction is driven by fear.
Anxiety, conversely, is a vague feeling of dread or apprehension. It can be triggered by external stimuli, but also entirely internal stimuli.
Like worrying about a test.
Right. It's the persistent worry about an upcoming examination or an unexplained, overwhelming sense of impending doom when you're sitting safely in your home.
So fear is, there is a bear in the room. Anxiety is, what if a bear breaks in tomorrow? Or what if I fail my exam about bear management?
Exactly the distinction. However, whether the trigger is a physical bear or perceived internal threat, the body's physiological response is identical.
And this brings us to a monumental concept in nursing science and human biology, which is Hans Selye's general adaptation syndrome.
Cilia was a pioneering endocrinologist. He mapped the precise biological pathway of how stress creates wear and tear on the human body.
He broke the syndrome down into 3 distinct phases: the alarm reaction stage, the resistance stage, and the exhaustion stage. Breaking down what is physically happening in each of these stages is crucial because it directly translates to the physical symptoms we assess on the floor. So let's start with the trigger, the alarm reaction stage.
The alarm reaction is the initial biological spark. The brain perceives a threat, real or imagined. The hypothalamus, which acts as the body's command center, instantly sends a distress signal to the adrenal glands.
The adrenal glands respond by dumping massive amounts of adrenaline, also known as epinephrine, and norepinephrine into the bloodstream. This is the raw fuel for the fight or flight response.
But raw fuel requires energy to burn. The body needs an immediate energy source to power the muscles to fight the bear or run away.
So what does it do?
Simultaneously, the hypothalamus sends signals to the major organs, specifically targeting the liver. The liver is commanded to halt its normal functions and immediately reconvert its stored glycogen back into glucose.
It essentially floods the bloodstream with raw sugar to provide instant, accessible food for the cells.
You now have the fuel from the adrenaline and the energy from the glucose. This propels the body into Cilia's second phase, the resistance stage.
This is where the autonomic nervous system completely takes over the vehicle.
Specifically, the sympathetic nerve fibers activate, charging up every vital sign in the body to maximize physical output.
The source text gets intensely specific about how the body ruthlessly rearranges its priorities here. It describes how blood is literally shunted away from organ systems that are deemed unnecessary for immediate survival.
Think about it from an evolutionary standpoint. If you are running from a predator, your body does not care about digesting your lunch, and it certainly does not care about reproduction.
Makes sense.
The sympathetic nervous system forcibly constricts the blood vessels supplying the gastrointestinal tract and the reproductive system.
This perfectly explains the avalanche of physical complaints anxious patients present with. The severe nausea, the profound dry mouth, the upset stomach, the feeling of butterflies. None of that is in their head.
No, it's not.
It is the physical sensation of their GI tract being starved of blood flow.
The blood isn't disappearing. It is being aggressively redirected. It is shunted into the heart, the lungs, and the major skeletal muscles.
To prepare for action.
Yes. The heart rate skyrockets to pump this highly oxygenated, glucose-rich blood to the limbs. The respiratory rate spikes to draw in more oxygen. The pupils dilate drastically to allow more light into the eye to scan for threats. The body transforms itself into a biological combat machine.
And if the person successfully adapts to the stress, or if the perceived threat is resolved, the parasympathetic nerve fibers eventually kick in.
They act as the body's dampener.
Right, reversing the process, slowing the heart rate, returning blood to the gut, and bringing the body back to a state of homeostasis. But what happens when the alarm doesn't shut off?
That leads to the third and most dangerous phase, the exhaustion stage. If the individual cannot adapt, or if the emotional components of the anxiety remain unresolved, the body's resources become entirely depleted.
Because they've been running on high gear for too long.
Exactly. The continual, relentless arousal of these physiological systems leaves the body with zero reserve capacity.
The body literally begins to break down. The text explicitly links this chronic exhaustion stage to the development of severe stress-related illnesses. We see the emergence of somatic symptom disorders where psychological distress manifests as severe, unexplained physical pain.
And we also see the exacerbation of medical illnesses. Chronic high blood pressure destroys blood vessels, and the chronic shunting of blood from the gut can trigger or severely worsen inflammatory conditions like ulcerative colitis.
This biological breakdown is driven by the underlying neurochemistry. To understand how we fix this with medication, we must look at what is happening between the neurons in the brain.
The clinical manual highlights 3 primary neurotransmitter systems you must understand: GABA, norepinephrine, and serotonin.
Let's unpack GABA first, which stands for gamma-aminobutyric acid. The text refers to GABA as the brain's natural anti-anxiety agent. The easiest way to visualize GABA is to think of it as the brake pedal in a car.
That analogy holds up perfectly at the molecular level. GABA is an inhibitory neurotransmitter.
Meaning it slows things down.
Yes. When it binds to its receptors, it opens chloride channels, allowing negative ions to flood into the neuron. This drastically reduces the cell's excitability, decreasing the rate at which neurons fire. It literally forces the central nervous system to slow down.
And in anxiety.
In patients with severe anxiety disorders, we see a profound dysfunction in the GABA system. The brake pads are worn out, the brake line is leaking.
Okay, so if GABA acts as the biological brakes, norepinephrine is the accelerator pedal.
Norepinephrine is a highly excitatory neurotransmitter, produced primarily in a region of the brainstem called the locus coeruleus.
Try saying that 3 times fast.
Right, but it drives the sympathetic nervous system's fight-or-flight response. Because GABA normally reduces anxiety and norepinephrine increases it, psychiatric researchers believe that anxiety disorders are fundamentally rooted in a regulatory failure between these two chemicals.
So there's an imbalance.
Yes. There's a chronic excess of norepinephrine flooding the system.
The third major player is serotonin. Now, in nursing school, serotonin is almost exclusively taught in the context of major depressive disorder. But it plays a massive role in anxiety as well, doesn't it?
It absolutely does. The serotonin system is vast, but specifically, a receptor subtype known as 5-hydroxytryptamine type 1A, or 5-HT1A, plays a critical role in modulating anxiety, aggression, and overall mood stability.
And the data shows a link.
The clinical data shows that severe dysregulation in serotonin pathways is heavily implicated in obsessive-compulsive disorder, panic disorder, and generalized anxiety disorder.
Let me bridge this neurochemistry back to the pharmacology for a moment. If a patient's GABA system is failing, their brakes are shot, do anxiety medications essentially function as synthetic brake fluid? Are we just artificially pressing the brake pedal for them?
That is precisely what anxiolytic drugs do, specifically the benzodiazepine class. Their primary molecular mechanism of action is to bind to the GABA receptor complex and enhance the affinity of GABA for its receptor.
So they make the existing GABA work better.
They amplify the inhibitory effect, forcing the neuronal firing rate to plummet, which subsequently drags those dangerously elevated vital signs back down to a safe baseline. You are chemically forcing the car to stop.
Understanding that mechanism makes the clinical assessment so much clearer. And that leads us to one of the most critical, heavily tested frameworks in psychiatric nursing, the 4 levels of anxiety.
The clinical guidelines are unambiguous on this point. The very first priority nursing action when approaching an anxious patient is to assess and identify their precise level of anxiety.
Because the intervention depends on it.
You cannot select a nursing intervention until you know the level, because an intervention that works for mild anxiety will be actively dangerous for a patient in panic.
We need to break down these 4 levels meticulously, starting with mild anxiety. What are the clinical findings a nurse will observe?
Mild anxiety is unique because it's actually a psychological asset.
Really? An asset?
Yes. The patient's perceptual field is incredibly wide. They are taking in their environment efficiently, their senses are sharpened.
But they still feel it physically, right?
Physiologically, they might report mild gastric distress, the classic butterflies in the stomach. They might have minor difficulty sleeping or present with mild restlessness and fidgeting. But psychologically, their motivation is highly increased, their problem-solving skills are optimal, and their ability to learn is at its absolute peak.
So imagine a nursing student the evening before the NCLEX exam. They're pacing a bit, maybe chewing on a pen, feeling restless, but their focus is laser sharp.
Exactly. So what is the required nursing intervention for a patient exhibiting mild anxiety?
Well, the clinical manual states that mild anxiety requires no direct intervention to reduce it. In fact, you should capitalize on it. This is the optimal designated time for patient teaching.
This is a major exam concept. You execute your complex preoperative teaching, your detailed discharge planning, and your new medication education only when the patient is at a mild level of anxiety.
Yeah.
They are biologically primed to absorb and process new information.
But the clinical picture shifts drastically when we escalate to moderate anxiety.
Moderate anxiety introduces the distinct, disturbing psychological feeling that something is very wrong.
The motivation turns to agitation.
The patient transitions from motivated to nervous and agitated. The physiological findings become pronounced. You'll observe increased muscle tension. Diaphoresis, visible sweating, begins.
And the heart rate.
Their pulse becomes pounding and rapid. They will likely report a tension headache, a profoundly dry mouth, and an urgent need for frequent urination.
Their speech patterns change too, right? Their vocal pitch gets higher and their rate of speech accelerates.
Yes, And psychologically, their perceptual field narrows significantly. They become selectively attentive, focusing only on the immediate task or fear.
So they miss the big picture.
They lose the ability to connect thoughts or events independently. We also see a marked increase in the use of automatisms.
Automatisms is a fantastic clinical term that we really need to define clearly.
Automatisms are automatic, unconscious, repetitive physical mannerisms that are biologically geared toward relieving anxiety.
Like what exactly?
We are talking about rhythmic finger tapping, aggressive leg bouncing, jingling keys in a pocket, or obsessively twisting hair. The frequency and physical intensity of these automatisms scale directly with the rising level of anxiety.
Let's create a clinical vignette. I walk into a patient's room. They are awaiting biopsy results. They are pacing back and forth, twisting their hair vigorously, sweating, and talking very rapidly about how long the doctor is taking.
Okay, classic presentation.
They are in moderate anxiety. What is my exact nursing intervention?
The critical threshold here is that a patient in moderate anxiety can still process information and learn, but absolutely not on their own. They require constant assistance and structure.
They can't guide themselves.
They cannot concentrate independently.
Yeah.
Your intervention is to actively manage their attention. You must speak in short, simple, easy-to-understand sentences. You have to pause frequently to ask them to repeat the information back to ensure they are actually processing it. And you must constantly redirect their wandering attention back to the necessary task.
So if I need to change their surgical dressing and they are rapidly talking about their dog at home and the hospital food, I need to say, I understand you are worried about your dog. Right now, I need you to look at this incision with me.
Perfect redirection. You acknowledge and you guide their narrowed focus back to the priority.
Right.
But once the patient crosses the threshold into severe anxiety, you throw that entire rulebook out the window.
Severe anxiety sounds like a system completely breaking down. What does this presentation look like?
It is a regression to primitive defensive responses. Cognitive skills decrease precipitously. The patient's perceptual field is reduced to a single, scattered detail.
So they can't focus on almost anything.
They're entirely incapable of completing tasks, solving problems, or learning anything new. Their behavior is frantically geared toward anxiety relief, but it is disorganized and completely ineffective.
The physical symptoms listed in the source text are brutal. A severe pounding headache, nausea, active vomiting, and diarrhea. Severe trembling and shaking.
It's a full somatic crisis.
A rigid, defensive physical stance. Vertigo, pale skin due to the vasoconstriction, extreme tachycardia, and crushing chest pain.
Psychologically, they may be sobbing uncontrollably, expressing feelings of awe, dread, or absolute horror. They frequently engage in bizarre ritualistic behaviors. And the most critical clinical finding, they no longer respond to redirection.
Which dictates a hard shift in nursing interventions. The text is definitive. If a patient is in severe anxiety, all teaching must immediately stop.
Continuing to teach a severely anxious patient is not just useless, it is antagonistic. You are bombarding a failing system with more data, which only agitates them further.
Your goal changes entirely.
Your singular overriding goal is to lower their anxiety level back down to moderate or mild. Only then can you proceed with any other nursing task.
The source material highlights a crucial safety protocol here, which is you must remain with the person. Leaving a severely anxious patient alone is guaranteed to worsen their condition.
You stay with them. You speak in a low, calm, soothing tone. If they are filled with kinetic energy and cannot sit still, you do not force them into a chair.
You walk with
them while you talk. In severe anxiety, the actual words you are saying matter far less than the rhythmic, calming tone of your voice. You physically model slow, deep, even breaths to try and coax their physiological arousal down through mirror neurons.
If those interventions fail, or if the initial trigger is overwhelmingly traumatic, we reach the final, most dangerous stage, panic.
Panic is the absolute dominance of the emotional psychomotor realm. It is pure, unfiltered fight, flight, or freeze.
The clinical presentation of panic is extreme. The perceptual field shrinks down to nothing but a focus on the self. The patient cannot process any external environmental stimuli.
They suffer from heavily distorted perceptions and a total catastrophic loss of rational thought.
This is the domain of the severe safety risks we outlined in the master sheet.
Yeah.
They cannot recognize physical danger.
They might become entirely mute and catatonic, just frozen in place. Or they might violently bolt and run blindly into walls or traffic.
Just trying to escape?
The sheer terror can induce transient delusions and hallucinations. Their pupils are maximally dilated, and their blood pressure and pulse are at dangerous extremes.
How does a nurse manage a patient in full panic?
Safety supersedes everything. You establish a safe environment immediately. You transport them to a small, quiet, non-stimulating room to sever the external sensory input.
And you stay with them.
And you maintain a continuous verbal anchor, even if they appear entirely unresponsive.
Because even if their cognitive brain cannot decipher your sentences, the tone of your voice provides a lifeline.
You continuously reassure them that what they are experiencing is anxiety, that they are in a safe, controlled environment, and most importantly, that this biological storm will pass.
That is a vital piece of knowledge. A panic attack is not an indefinite state. The text confirms they typically last between 5 and 30 minutes.
Right. To the patient, it feels like an eternity of dying. But the nurse knows the biological engine will eventually run out of fuel. You remain present until the tide recedes.
I want to address a deeply psychological component of nursing care here. When you are trapped in a small room with a patient experiencing the sheer terror of a panic attack, your own autonomic nervous system will try to match theirs. Anxiety is highly contagious.
The source material addresses this phenomenon by referencing the foundational nursing theories of Hildegard Peplau and Harry Sack-Sullivan. They documented how anxiety is communicated interpersonally through empathy.
Empathy, in this theoretical framework, is defined as walking in another person's shoes for a moment in time.
It is the visceral feeling you get when you look into the dilated, terrified eyes of a patient, or when you walk into a room where two people were just screaming at each other and you can physically feel the tension in the air.
Because of this empathetic contagion, the clinical manual mandates self-awareness as a primary nursing intervention. The nurse must constantly monitor their own internal anxiety level.
If the nurse's anxiety begins to escalate, they lose their therapeutic effectiveness. You cannot pull a drowning patient out of the water if you're also drowning.
That makes perfect sense.
The nurse must actively regulate their own breathing, evaluate their own discomfort, and maintain internal control because the patient is entirely reliant on the nurse's external stability.
You have to master your own physiology before you can manage theirs. Let's shift our focus and delve deeply into specific diagnoses, utilizing the nursing model to frame our understanding. We have extensively covered the acute, terrifying state of a panic attack. How does that isolated event transition into a chronic diagnosis of panic disorder?
Experiencing a single panic attack does not meet the diagnostic criteria for panic disorder.
So what does?
Panic disorder is specifically diagnosed when a patient suffers from recurrent unexpected panic attacks, which are then followed by a minimum of 1 month of persistent, agonizing worry about when the next attack will strike, or a significant detrimental change in their behavior to avoid future attacks.
The source notes a terrifying hallmark of this disorder. The initial attacks are almost always spontaneous. There is no trigger. There is no stressful event. The patient could be watching a comedy on television and the attack just detonates.
That spontaneity is exactly what breeds the persistent, crippling worry. If you know dogs cause your anxiety, you can avoid dogs. If your own body randomly attacks you without provocation, you can never escape the threat.
And who is most at risk?
The clinical onset typically peaks in late adolescence through the mid-30s, and epidemiological data shows a significantly higher prevalence in females.
What does the pathophysiology and risk factor profile look like for panic disorder?
The research demonstrates a clear genetic susceptibility. First-degree relatives of clients with severe anxiety have statistically higher rates of developing the disorder.
So it runs in families.
It is described as having moderate heritability, which means the etiology is a complex interaction of genetic predispositions and non-genetic environmental factors. The genetics load the gun, but additional factors, specifically severe early childhood trauma or profound life stressors, are required to pull the trigger and manifest the disorder.
When a patient presents with suspected panic disorder, what expected findings should the nurse document? The source material provides an incredibly detailed assessment tool called the Hamilton Rating Scale for Anxiety.
It's a very robust tool.
Let's break down the data it captures. What subjective findings will the patient report?
Subjectively, the patient will express profound fears of losing their mind. You will hear phrases like, "I feel like I'm going crazy," or "I was absolutely certain I was having a fatal heart attack, but the emergency room doctors told me my heart is fine."
And during the attack itself?
During the attack itself, they frequently describe two terrifying dissociative symptoms. First is depersonalization, where they feel completely disconnected from their own physical body. Second is derealization, where they perceive their surrounding environment as entirely fake, distorted, or unreal.
The Hamilton scale organizes these symptoms meticulously. It evaluates anxious mood, which captures the constant worrying and anticipation of the worst possible outcome. It measures tension, which includes an exaggerated startle response, constant trembling, and a total inability to physically relax.
It also identifies intellectual or cognitive deficits, specifically poor memory retention and a severe inability to concentrate due to the cognitive load of the anxiety.
And we must document the avalanche of somatic physical complaints. The Hamilton scale lists cardiovascular symptoms like extreme tachycardia, forceful palpitations, debilitating chest pain, and sensations of imminent fainting.
Respiratory symptoms include a crushing pressure in the chest, a sensation of choking and dyspnea, or severe shortness of breath.
The gastrointestinal symptoms are also prominent. Difficulty swallowing, profound nausea, active vomiting, rapid weight loss, and a highly specific term, borborygmi. We briefly touched on this earlier, but let's define it clearly for clinical documentation.
Borborygmi is the medical terminology for the loud, hyperactive, rumbling or gurgling noises generated by the rapid movement of fluid and gas through the intestines.
Like a severe stomach growl.
It is a severely hyperactive stomach growl. And tying this directly back to Selle's general adaptation syndrome, this severe GI distress is the direct physiological consequence of the sympathetic nervous system violently manipulating and cutting off blood flow to the gut during the stress response.
We also look for objective behavioral findings. The intense pacing, the rapid pulse, the frantic automatisms, but the priority nursing assessment always returns to safety red flags.
Always.
We already established the severe suicide risk, particularly in unpartnered younger females, and the risk of physical injury from bolting. But the text adds another layer of safety assessment, evaluating severe nutritional and sleep deficits.
The persistent apprehension and dread between the actual attacks can utterly destroy a patient's sleep architecture. They may spend 10 hours in bed, but achieve zero restful, restorative sleep.
And the nausea.
Furthermore, the chronic nausea and GI distress can cause complete anorexia, leading to dangerous weight loss. Or, conversely, the patient may compulsively binge eat to self-soothe the anxiety. These basic physiological deficits, sleep and nutrition, must be evaluated and stabilized by the nurse.
Let's examine how panic disorder can metastasize into agoraphobia. The text indicates that roughly 50% of individuals diagnosed with panic disorder will develop accompanying agoraphobia.
The literal translation of agoraphobia is fear of the marketplace, but in modern clinical practice, it defines an intense fear of being outside the home or in public spaces where escape might be difficult or help might be unavailable if a panic attack occurs.
How does that develop?
The pathology develops because the traumatic memory of the panic attack, fused with the absolute terror of experiencing another one in public, drives massive avoidance behavior. The patient systematically restricts their life to avoid triggering an attack.
The source describes patients who become entirely homebound. The mere thought of stepping onto their front porch induces panic. Others might be able to leave the house, but their safe zone is restricted to a 2-block radius.
This pathology introduces a crucial, highly testable psychiatric concept: primary and secondary gains. Understanding these psychological mechanisms is essential for comprehending why these detrimental behaviors are so fiercely maintained by the patient.
Let's define the mechanism of a primary gain.
Primary gain is the immediate direct relief of anxiety that the patient achieves by executing the specific anxiety-driven behavior.
So for the agoraphobic patient?
For the agoraphobic patient, the primary gain is powerful. By refusing to leave their house, they successfully eliminate the agonizing anticipatory anxiety of having a panic attack in public.
It's a highly effective short-term strategy. It successfully prevents the panic.
Exactly. But it traps them in a prison of their own making. This leads to the secondary gain. Secondary gain is the external attention, support, and tangible benefits the patient receives from others as a direct result of being sick and maintaining these behaviors.
Give me an example of that.
For example, because the agoraphobic patient cannot leave the house, a spouse or family member steps in to do all the grocery shopping, run all the errands, manage all external affairs, and shower the patient with constant caring concern.
The family members unwittingly become enablers.
Precisely. The family acts out of genuine compassion, but their actions actively reinforce the pathological agoraphobic behavior. The patient is receiving profound secondary benefits, like attention, care, and the removal of life responsibilities just from remaining sick.
Breaking that cycle requires precise nursing interventions and milieu management. Let's return to the acute clinical setting. A patient on your unit has just endured a severe panic attack. It lasted 20 minutes, the biological storm has passed, and their anxiety level has dropped back to mild or moderate. What is the priority nursing action now?
Once the autonomic nervous system resets and cognition begins to return, the nurse transitions to therapeutic exploration.
Yeah.
You utilize open-ended communication techniques. You never attempt this during the attack, only after.
What do you say?
You might approach the patient and say, "It appears your anxiety is subsiding. Can you share with me what you were experiencing a few minutes ago?"
You are guiding them to explore their emotional responses and attempting to identify any subtle environmental or internal triggers.
Yes, and crucially, this post-crisis period is the exact window when you introduce and teach relaxation techniques. You teach deep breathing exercises, progressive muscle relaxation, and guided imagery.
This brings us to a massive NCLEX logic trap that the source text explicitly warns about. Exam writers love to test this specific boundary.
They really do.
The question will present a scenario where a patient is hyperventilating, pacing frantically, and in the throes of a full panic attack. One of the multiple choice interventions will invariably be teach the patient deep breathing exercises. Why is selecting that option a guaranteed failure?
Because of the single word, teach. We established that during severe anxiety and panic, the cognitive ability to learn is completely obliterated. If a patient is actively hyperventilating in a panic attack, you guide them to breathe.
You do it with them?
You sit with them, you breathe audibly and slowly, and you attempt to pace their respirations. But you absolutely do not attempt to teach the mechanical technique. You only teach the technique when they are at baseline, calm, and capable of learning, so they can practice it and weaponize it as a tool when they feel the anxiety beginning to escalate.
That is the essence of clinical judgment. You constantly evaluate the patient's anxiety level, and you ruthlessly match your intervention to their exact cognitive capacity in that specific second. Let's expand our scope to phobias and generalized anxiety disorder, or GED. How does the anticipatory anxiety seen in these conditions differ from the spontaneous terror of panic disorder?
As we discussed, a spontaneous panic attack detonates without warning. Phobias and GAD operate on a different mechanism. A phobia is defined as an illogical, intensely powerful, and persistent fear of a highly specific object or a specific social situation.
It's focused.
This fear causes extreme psychological distress and heavily interferes with normal daily functioning.
An interesting nuance from the text is that these specific phobias rarely result from a past negative experience with the object. A patient can suffer from a debilitating phobia of snakes without ever having been bitten by one, or perhaps having never even seen one outside of a television screen.
The fear response is entirely disproportionate to the actual threat. Furthermore, the patient often possesses full insight. They know their fear is irrational and illogical, but they feel completely powerless to suppress the biological reaction. The mere thought of encountering the phobic object generates massive anticipatory anxiety, which drives complex avoidance behaviors.
The clinical manual categorizes specific phobias into 4 distinct subtypes. First are natural environmental phobias, which include severe fears of storms, deep water, or heights. Second are blood injection phobias, defined as an extreme fear of seeing blood or undergoing invasive medical procedures like receiving an injection.
From a nursing perspective, a blood injection phobia severely complicates basic clinical care. If that patient requires a life-saving FIE placement or a critical blood draw, the nurse must navigate a massive anxiety response, potentially including vasovagal syncope, where the patient actually faints from the anxiety.
The third category encompasses situational phobias. This includes the fear of driving over bridges, driving through tunnels, riding in elevators, being in small enclosed rooms, or flying in airplanes.
And the final category is animal phobias. The text notes that cats and dogs are statistically the most common phobic objects, and these specific fears typically originate in childhood and persist tightly into adulthood.
We must also deeply examine social anxiety disorder, previously known as social phobia. This is severe, paralyzing anxiety provoked by the prospect of certain social or performance situations.
This isn't just stage fright before giving a major speech. It can be triggered by attending a social gathering alone, eating food in a public restaurant, or simply using a public restroom.
The etiology of social anxiety disorder, according to the text, is deeply rooted in profound low self-esteem and an overwhelming obsessive concern about the negative judgments of others. The patient is terrified of appearing socially inept, looking foolish, or doing something publicly humiliating.
Now contrast that highly specific situational fear with generalized anxiety disorder.
Mm.
In GDD, the patient's worry is not anchored to a specific object, animal, or social event.
It's free-floating.
A patient diagnosed with GAD worries excessively and experiences high levels of anxiety regarding multiple aspects of life for at least 50% of the time, consistently for a duration of 6 months or more. They feel entirely incapable of controlling the worry.
To meet the clinical diagnostic criteria for GAD, the patient must also present with 3 or more specific physical symptoms. These include chronic uneasiness, severe irritability, persistent muscle tension, debilitating fatigue, difficulty concentrating or thinking clearly, and severe sleep alterations.
A fascinating clinical reality is that we see a much higher volume of patients with GAD in primary care family physician offices than we do in acute psychiatric settings.
Because of the physical symptoms.
Exactly. They're constantly seeking medical interventions for their physical symptoms, the chronic muscle tension, the relentless fatigue, the insomnia, long before anyone realizes the root cause is a systemic anxiety disorder.
Once the diagnosis is established, how do we treat these disorders? The source material relies heavily on therapeutic interventions, specifically detailing cognitive behavioral therapy, or CBT. Nurses need to understand the mechanics of these specific CBT techniques to reinforce them on the floor.
They are crucial tools.
Let's break them down, beginning with positive reframing.
Positive reframing is the systematic process of identifying negative, catastrophic internal messages and actively replacing them with positive, rational ones. During an anxiety episode, the patient's internal monologue is screaming, "My heart is pounding out of my chest. I am going to die right now."
So how do they reframe that?
The CBT therapist trains the patient to actively intercept that thought and replace it with, "My heart is pounding because I am experiencing anxiety. I can withstand this. It is uncomfortable, but it is not lethal and it will eventually pass." Patients will often write these reframe statements on index cards to carry in their wallets for immediate access during a crisis.
The next technique is decatastrophizing. This seems to involve taking the runaway what-if scenario and aggressively grounding it in objective reality.
Exactly. The therapist utilizes targeted questioning to force the patient to realistically appraise the feared situation. The therapist will ask, "What is the absolute worst thing that could possibly happen in this scenario? Statistically, how likely is that to actually occur? If the worst-case scenario did happen, could you survive it?"
Is the reality of the situation truly as devastating as your imagination is projecting?
Right. It forces the logical prefrontal cortex to analyze and dismantle the irrational fear generated by the amygdala.
And we have thought stopping. The clinical manual provides some very physical, tactile examples of this technique.
Thought stopping is designed to violently jolt the patient's brain out of a spiraling cycle of negative ruminating thoughts. It requires an immediate sensory interruption.
Like splashing cold water.
Splashing the face with ice-cold water, shouting a specific word aloud, or the most common physical technique, snapping a rubber band worn around the wrist. The sharp, sudden sensory input of the rubber band snapping against the skin interrupts the neurological anxiety loop, providing a brief window for the patient to implement positive reframing.
The final CBT technique listed is assertiveness training.
Assertiveness training empowers the patient to take active control over their life and effectively negotiate interpersonal conflicts without defaulting to anxiety or passive-aggressive avoidance.
How does it work?
The training focuses heavily on the utilization of I statements to clearly communicate feelings and boundaries. Instead of a patient saying, "You are always ignoring me and making me anxious," they are trained to say, "I feel angry and anxious when you turn your back while I am attempting to speak with you." It fosters internal self-assurance and reduces the anxiety associated with interpersonal friction.
Those are the core cognitive strategies. But the text also details intensive behavioral therapies, which are utilized primarily for specific phobias. There are 2 major modalities: systematic desensitization and flooding. Let's examine the mechanics of systematic desensitization first.
Systematic desensitization is a highly structured, gradual exposure process. The therapist progressively exposes the client to the threatening phobic object in a strictly controlled, safe environment.
Step by step.
Each sequential exposure increases slightly in intensity, but the patient uses relaxation techniques to ensure their anxiety level decreases before moving to the next step. For example, if a patient has a debilitating phobia of flying, the first session might simply involve holding a small plastic toy airplane and discussing its features.
Once their anxiety regarding the toy plane drops to 0, they progress. The next session might involve holding a larger, more realistic model plane. Then perhaps they visit an airport and watch planes take off from a distance. Then they sit in a stationary parked aircraft. Finally, after weeks or months, they take a short, actual flight.
It is serial, incremental desensitization. The successful reduction of anxiety at each progressive step serves as powerful positive reinforcement, gradually retraining the brain's threat response.
Now, contrast that slow, careful process with flooding. The clinical text describes flooding as rapid desensitization. The therapist confronts the client with their ultimate phobic object, the absolute worst fear, immediately and continuously until the object no longer produces an anxiety response.
The biological premise behind flooding is that the client is forced to experience the absolute apex of their fear response. They endure the maximum physiological arousal, they realize that the phobic object did not kill them, and the neurological anxiety response eventually exhausts itself and burns out.
I have to challenge this intervention. Flooding sounds incredibly traumatizing, inherently dangerous, and bordering on cruel. Is this truly a standard nursing intervention? If my patient is admitted to the medical floor and has a severe phobia of spiders, am I expected to initiate flooding by throwing a tarantula on their bed to cure them?
That is an incredibly important challenge, and the answer is absolutely unequivocally no. This represents a definitive boundary for nursing practice and a highly testable ethical and legal limit.
Okay, good.
The source text explicitly dictates that flooding is a profoundly anxiety-producing, high-risk procedure. It must only be conducted by highly trained, specialized psychotherapists under strictly controlled clinical circumstances and absolutely requires the explicit, informed consent of the client prior to initiation. It is never a standard bedside nursing intervention. A nurse's role might involve providing emotional support to a patient who is undergoing this specific therapy with an outside specialist, but a nurse does not prescribe or initiate flooding.
That distinction is a massive relief and a vital point for establishing safe practice boundaries. We have thoroughly covered the therapeutic interventions, the milieu management, and the communication strategies. We must now transition to the most heavily tested, complex component of psychiatric nursing, the pharmacy. We know how to manage the behavioral crisis and restructure the environment. Now we must address how to fix the underlying neurochemical imbalance.
Pharmacology requires deep understanding, not just memorization. We are targeting the specific neurotransmitter systems we mapped out earlier: GABA, norepinephrine, and serotonin. Let's begin with the heavy artillery used for acute severe anxiety crises, the benzodiazepines.
Referencing the clinical manual's pharmacological tables, we are examining medications such as diazepam, which is Valium, alprazolam, which is Xanax, chlordiazepam epoxide, or Librium, lorazepam, or Ativan, clonazepam, known as Klonopin, and oxazepam, or Cerex.
The foundational knowledge for benzodiazepines is their mechanism of action. They act as powerful GABA agonists. They slam on the central nervous system's brakes.
Yeah.
Because they force the immediate opening of chloride channels and depress neuronal firing, they are incredibly effective for the rapid, short-term obliteration of severe anxiety and panic.
The clinical text categorizes these drugs by their speed of onset and their biological half-life. For instance, diazepam and alprazolam possess a very fast onset of action. Diazepam, however, has a massive half-life, ranging from 20 to 100 hours. Conversely, clonazepam and oxazepam have a much slower onset. Why must a bedside nurse memorize these pharmacokinetic profiles?
Because it dictates your clinical judgment in an emergency. If your patient is actively hyperventilating in the midst of an acute panic attack right now, you require medication with a fast onset, like alprazolam or diazepam, to immediately halt the biological cascade.
But you have to watch that half-life.
However, you must also calculate the half-life. If you administer diazepam with its 100-hour half-life, especially to an older adult with decreased liver function, you must monitor them for prolonged sedation and toxicity for days after the single dose.
Let's delve into the side effects and the critical safety red flags. Because chemically slamming on the brain's brakes carries severe systemic consequences.
The primary side effect profile is profound central nervous system depression. You will assess and document dizziness, severe clumsiness and ataxia, heavy sedation, lethargy, blurred vision, dry mouth, and constipation due to the slowed GI motility.
And the dependence risk.
But the paramount clinical red flags are the immense potential for chemical dependence, misuse, and life-threatening withdrawal.
The source material is adamant. These drugs should ideally be prescribed for no longer than 4 to 6 weeks.
They are a temporary bridge. They are designed to artificially suppress the anxiety just enough to allow the patient to engage in CBT and learn internal coping mechanisms. They are not a permanent neurochemical cure.
And stopping them suddenly.
A critical mandate for patient education is that a patient must never, under any circumstances, abruptly discontinue a benzodiazepine. Abrupt cessation removes the artificial brakes immediately, causing a massive rebound excitation of the nervous system that can trigger severe withdrawal symptoms, including lethal seizures.
What other mandatory education must the nurse provide to a patient being discharged on a benzodiazepine prescription?
The nurse must explicitly instruct the patient to entirely avoid all other CNS depressants. This means absolutely no alcohol consumption, no over-the-counter antihistamines, which cause compounding sedation.
What about caffeine?
Interestingly, they must also avoid heavy caffeine intake, as the stimulant properties directly counteract the desired anxiolytic effect of the drug. Furthermore, they must be warned against operating heavy machinery or driving due to the delayed reaction times and clumsiness. Finally, they must be taught to rise slowly from a lying or sitting position to combat orthostatic hypotension, a sudden drop in blood pressure upon standing, which can easily induce a syncopal episode or fainting.
That covers the short-term, fast-acting, high-risk benzodiazepines. Now we shift to the long-term maintenance medications. First is the non-benzodiazepine anxiolytic class, represented primarily by buspirone, also known as Buspar.
Buspirone is structurally and functionally a completely different entity. It operates primarily as a partial agonist at the serotonin 5-HT1A receptors.
So it works on serotonin, not GABA.
Exactly. It is highly effective for the long-term management of generalized anxiety disorder and social phobias, but its defining clinical characteristic is its very slow onset of action. It can take weeks of continuous daily dosing to achieve a therapeutic effect. It will do absolutely nothing to stop an acute panic attack.
That pharmacokinetic reality sounds like the perfect setup for a classic NCLEX trap question. The scenario will read, a patient is experiencing an acute panic attack with a heart rate of 140. Which PRN medication does the nurse administer? Option A, buspirone. Option B, lorazepam.
It is a textbook trap. You never select buspirone for an acute crisis. It lacks the rapid GABA-enhancing properties required to stop a panic attack.
What are the specific nursing implications and teaching points for buspirone?
Patient education must include instructing them to take the medication consistently with food to enhance absorption and decrease gastric irritation. Importantly, the nurse must monitor for a highly specific paradoxical adverse effect, paradoxical excitement or euphoria.
Paradoxical excitement.
In a small subset of patients, instead of providing anxiolytic calm, buspirone can induce severe restlessness, agitation, and escalating anxiety. If this paradoxical reaction occurs, the patient must be instructed to report it to the prescribing physician immediately.
Next in the pharmacological arsenal are the antidepressants, specifically the SSRIs, or selective serotonin reuptake inhibitors. This includes widely prescribed medications like fluoxetine, paroxetine, and sertraline.
Right, Prozac, Paxil, Zoloft.
In nursing fundamentals, these are taught as the primary treatment for major depressive disorder, but the clinical manual designates them as the preferred, gold standard long-term treatment for severe anxiety disorders, particularly in the older adult population.
They are the long-term solution because they structurally modify the serotonin pathways we discussed earlier. By inhibiting the reuptake of serotonin, they leave more of the neurotransmitter available in the synaptic cleft, gradually downregulating the receptors and stabilizing the mood and anxiety circuits.
And they work well for maintenance.
They are highly effective for maintaining remission in panic disorder, social phobia, and GAD. However, there is a massive, incredibly dangerous nursing consideration when initiating SSRI therapy in the older adult demographic.
The source material explicitly warns that when prescribing SSRIs to an older adult, the provider must initiate the drug at a significantly lower dose than the standard starting dose for a younger adult. What is the biological mechanism behind this warning?
The mechanism is rooted in receptor sensitivity. If an older adult whose neurological system is more fragile and less adaptable is immediately started on a standard or high dose of an SSRI, the sudden massive surge of serotonin in the synapses overstimulates the receptors.
Oh, so backfires.
Instead of calming the patient, this initial serotonin shock actually exacerbates and severely spikes their anxiety and agitation levels. Their system cannot tolerate the rapid chemical shift. Therefore, the clinical mandate is to start low and go slow, titrating the dosage up over weeks to allow the receptors to gradually adapt.
The clinical text also details a few alternative medication classes occasionally utilized for specific anxiety symptoms, notably the antihypertensives. It lists clonidine, which functions as an alpha-adrenergic agonist, and propranolol, which is a beta blocker.
Utilizing cardiac medications for anxiety is a fascinating pharmacological strategy. These drugs do not cross the blood-brain barrier in a way that significantly alters the core emotional or psychological components of anxiety.
So how do they work for anxiety?
Instead, they operate peripherally, directly blocking the sympathetic nervous system's physical symptoms. They forcibly lower the heart rate, block the adrenaline receptors on the heart to stop palpitations, and reduce scalable muscle tremors.
Like for stage fright.
For a patient suffering from debilitating social anxiety or severe performance stage fright, administering propranolol prior to the event will physically prevent their hands from shaking, their voice from quivering, and their chest from pounding. By eliminating these terrifying physical sensations, the patient's psychological anxiety is subsequently reduced, as they no longer feel the physical panic escalating.
That perfectly illustrates the intricate connection between the mind and the body's autonomic responses, which transitions us perfectly into our final major area of focus: special populations and exam strategy. We have mapped out the core presentations and interventions. Now, how do these clinical pictures alter across the lifespan, and exactly how will the nursing board exams test your mastery of these concepts? Let's analyze the pediatric population first.
Psychiatric presentations in children exhibit specific developmental variations. The clinical manual highlights separation anxiety disorder, characterized by excessive, developmentally inappropriate anxiety concerning separation from the home or primary caregivers.
That's common in toddlers, though, right?
While common in toddlers, it becomes a clinical disorder when it persists or emerges prior to age 18 and interferes with functioning. We also frequently encounter selective mutism.
Selective mutism is a fascinating condition. It is diagnosed when a child consistently fails to speak in specific social situations where there is an expectation for speaking, like in a classroom, despite demonstrating that they are perfectly capable of normal speech in other environments, like chattering constantly at home.
It is not a refusal to speak out of defiance. It is a paralysis driven by a profoundly high level of social anxiety. The vocal cords literally freeze. Fortunately, the source text provides an evidence-based practice intervention. It highlights a highly successful CBT adaptation known as the Coping Cat program.
Coping Cat is an excellent, memorable title for a pediatric intervention.
It is a structured, manualized version of cognitive behavioral therapy, meticulously designed specifically for pediatric and youth anxiety. The clinical research validates its high efficacy. Furthermore, its structured nature allows for flexible delivery methods. It can be successfully administered in school settings, community clinics, and increasingly via telehealth or computer-guided modules. This adaptability drastically increases access to effective, specialized treatment for children who might otherwise remain untreated.
Shifting to the extreme opposite end of the lifespan, older adults. What are the paramount clinical takeaways for the geriatric population?
The foundational diagnostic principle here is that severe anxiety that manifests for the very first time late in life is exceedingly rarely a primary independent new diagnosis of an anxiety disorder.
Meaning if an 80-year-old suddenly develops severe anxiety out of nowhere, it is almost certainly a secondary symptom tied to a different underlying pathology.
Precisely. Late-life onset anxiety is a massive red flag demanding a thorough medical workup. It is frequently the initial presenting symptom of underlying depression, early-stage dementia, an acute physical illness, or severe medication toxicity or withdrawal.
What if it is a primary anxiety disorder?
When primary anxiety disorders do occur in older adults, phobias, particularly agoraphobia and GAD, are statistically the most common. Interestingly, late-onset agoraphobia in this population frequently develops abruptly following a specific physical illness or a physical trauma, such as a devastating fall that shatters their confidence or being the victim of a mugging.
And we must reiterate the crucial safety flag for older adults that we introduced in the master sheet, as it is a guarantee to appear on nursing exams.
Despite the overwhelming clinical evidence and explicit warnings, medical providers unfortunately continue to prescribe benzodiazepines to older adults. As a nurse, you must recognize that this practice is directly associated with a drastically increased risk for falls.
It's just too sedating.
The combination of medication-induced sedation, psychomotor clumsiness, and orthostatic hypotension creates a lethal fall risk, frequently resulting in catastrophic injuries, such as hip fractures, which carry a high mortality rate in the elderly.
That brings us to our final synthesis, the NCLEX logic summary. We have dissected a massive volume of complex psychiatric material. Let's distill this entire deep dive into the 4 golden rules of test-taking strategy.
Rule number 1, the priority action. When an exam question presents a patient exhibiting any physical or psychological symptoms of anxiety, your absolute first nursing action is always, without exception, to assess and categorize their specific level of anxiety: mild, moderate, severe, or panic. You cannot safely select a nursing intervention until you have identified their current cognitive capacity.
Rule number 2, the first intervention for severe or panic level anxiety.
If the assessment confirms severe anxiety or full panic, your immediate intervention is presence and safety. You stay with the patient. You absolutely never leave them alone. You rapidly reduce environmental stimuli by relocating them to a small, quiet, contained room. And you prioritize their physical safety above all other clinical goals.
Rule number 3, the principle of the least restrictive environment.
Nursing board exams relentlessly test this ethical and legal principle. Before you ever select an option that involves chemical restraints, such as administering a PRN injection of haloperidol or lorazepam, or applying physical restraints, you must always attempt the least restrictive intervention first.
De-escalation first.
Moving an escalating patient to a quiet room and utilizing verbal de-escalation techniques is always less restrictive than forcibly altering their neurochemistry with a needle. You must exhaust your interpersonal skills and environmental management strategies before escalating to restraints.
And finally, rule number 4, medication recognition and pharmacokinetics.
You must intimately know your onset times. If the clinical scenario describes a patient in the throes of an acute active panic attack, you must search the options for a fast-acting benzodiazepine, like alprazolam. You must aggressively eliminate any options suggesting a slow-acting drug like buspirone or a long-term maintenance SSRI, as these will be entirely ineffective for resolving the immediate crisis.
This has been a profoundly comprehensive clinical masterclass. Let's lock in the highest yield takeaways one final time. We established that the 4 distinct levels of anxiety absolutely dictate your nursing interventions. Mild anxiety is your window for teaching. Panic is a state of pure biological survival.
Yes.
We verified that managing a panic attack requires your continuous physical presence and the immediate creation of a safe, non-stimulating environment. We analyzed the neurochemistry, identifying GABA as the braking system targeted by short-term benzodiazepines, while SSRIs act as the long-term solution by remodeling the serotonin receptors.
And safety is always priority.
Above all, we confirm that patient safety, whether mitigating the severe suicide risk in unpartnered young females, preventing a terrified patient from bolting into traffic, or protecting an elderly patient from a medication-induced hip fracture, is the ultimate overriding priority of psychiatric nursing.
Beyond the exams, beyond the pharmacology and the care plans, I want to leave you with one final paradigm-shifting thought regarding how you view these specific patients on the hospital floor.
I'd love to hear it.
Anxiety disorders are fundamentally not just all in someone's head. They are a very real, systemic, physiological hijacking of the human body's most ancient evolutionary survival tools. The pounding heart, the aggressive shunting of blood from the gut to the muscles, the drastic narrowing of the perceptual field, their bodies performing flawlessly.
It's doing what it was designed to do.
It is doing exactly what it was biologically designed to do to survive a lethal predator attack. The tragedy is simply that it is reacting to a false alarm. What if we shifted our clinical perspective and taught our patients to view their severe anxiety not as a manifestation of a broken, defective brain, but rather as an incredibly loyal, hyper-vigilant biological bodyguard that simply needs to be gently, systematically retrained?
I think that completely changes the level of empathy and respect we bring to the bedside. Instead of feeling frustrated and asking, why can't this patient just calm down, we start asking, how can I strategically help this patient retrain their biological alarm system? It is a powerful, deeply compassionate shift in nursing practice. Well, that brings us to the conclusion of this incredibly extensive deep dive. I encourage you to take a slow, deep breath, perhaps practice a few of those stress management and positive reframing techniques on yourself, and go out there and absolutely crush those board exams and your clinical rotations. Thank you for joining us.